picture this. You just got a vaccine, or maybe, you're at home managing one of those GLP-1 weight loss injections.
Right. The ones that are everywhere right now.
Exactly. So the needle comes out, and your immediate instinct, I mean, the thing you've probably done your entire life, is to press down on the little cotton ball and just give the area a really firm, vigorous rub.
Yeah, everybody does that. You think you're like dispersing the medicine or something.
Right. You think you're helping it heal, but then a few hours later, you look down, and your arm or your stomach looks like a heavily bruised balloon.
It's honestly the ultimate biological backfire.
Oh, totally.
Because you just triggered a massive cascade of tissue damage simply because you, completely misunderstood what the body was trying to do in those first critical seconds.
And that is exactly what we are tearing into today on this deep dive.
It's a really fascinating topic.
It really is. We've got this amazing stack of medical sources in front of us today. We're talking like advanced gastrointestinal trauma manuals, plastic surgery guidelines, and some seriously intense dental case reports.
Yeah, the dental ones are wild.
Oh, they are crazy. But we are hunting down the biological cheat codes for one specific mission today, and that is, what is the optimal post-injection compression protocol to minimize immediate swelling and oozing?
Because it matters so much more than people realize.
Exactly. Because whether you're sitting in a dentist chair getting numb or, injecting a medication at home, the way you or your doctor applies pressure in those first few seconds dictates whether you heal seamlessly or spend a week trying to cover up a massive hematoma.
Right.
So, okay, let's unpack this, because before we get into the crazy specific stuff, we need to talk about the biology of the bleed.
Yeah, to understand why that rubbing instinct is so destructive, we really have to look at the rigid biological clock governing hemostasis.
Hemostasis, meaning the process of stopping blood flow, right?
Exactly. When a needle pierces a vessel, your body doesn't just instantly, plug the leak. It initiates a highly choreographed two-step sequence.
2 steps, okay.
Right. So first, platelets flood the area, and it takes them about 30 seconds to stick together and form what we call a soft plug.
So it's like half a minute to get the initial patch on the leaky pipe.
Yes, but, and this is the crucial part, that 30-second plug is incredibly fragile.
It's just barely holding on.
Pretty much. People assume the bleeding has stopped because they don't see blood on the surface anymore, but that plug has almost zero structural integrity.
Oh, wow.
To actually secure the seal, the body needs a full 2 to 3 minutes to weave a protein called fibrin through those platelets, essentially cross-linking them into a durable matrix.
Okay, so it's like patching a pipe with quick-dry cement.
That's a good way to look at it.
Yeah, at 30 seconds, you've just smeared the wet paste over the hole.
Yeah.
It looks covered, but if the water pressure spikes even a little, it blows right out. You need the full 3 minutes for it to cure.
I'd actually take that analogy a step further. The platelets are the wet concrete, but the fibrin acts like steel rebar getting dropped into the mix.
Oh, nice. Yeah.
Without the rebar, the concrete just crumbles under pressure. It literally takes 2 to 3 minutes for that rebar to properly set.
Okay, but I am an incredibly impatient person.
Most of us are.
Right. So if I know it takes 3 minutes, my instinct is to just push my thumb down as hard as humanly possible. If I apply massive force, doesn't the rebar set faster?
It absolutely does not.
Damn it.
I know. And the trauma sources actually address this misconception directly. Pushing harder does not speed up the biological clock.
It just feels like it should,
It does, but in fact, applying heavy flat pressure with your thumb often crushes the surrounding healthy capillaries.
Oh, so you're making it worse.
Yeah, you're creating collateral damage without effectively sealing the target vessel at all. Which is why the advanced trauma manuals advocate for something completely different. They call it the pyramid dressing.
The pyramid dressing.
Yeah, or sometimes it's called the nugget method.
Nugget method. Okay, I love that. What is a nugget method?
Well, it relies on really basic physics. Instead of flattening a large piece of gauze with your whole thumb, you fold a small piece of gauze into a tight, dense little nugget.
Okay, so it's super concentrated.
Right. You place that precisely on the microscopic puncture wound. Then you layer slightly larger pieces of gauze over it so it creates an inverted pyramid. And then you apply gentle pressure to the very top.
Because pressure equals force divided by area.
Exactly.
So by concentrating all your force onto that tiny area at the tip of the pyramid, you get maximum localized pressure on the nicked vessel without just crushing a 2-inch radius of healthy tissue around it.
Exactly. You are artificially collapsing just that one vessel. Minor hemorrhage usually ceases after 2 to 3 minutes of this targeted occlusion.
But you still have to wait the 3 minutes.
You do. The catch is patience. If you lift that gauze at, say, the 1-minute mark just to peek,
Which everyone does.
which everyone does, if you peek to see if it stopped bleeding, you physically rip the uncured fibrin rebar right out of the tissue.
Oh, gross. And then the clock just resets to 0.
Pretty much, yeah.
Okay, so for a standard skin puncture, the golden rule is 2 to 3 minutes of focused, undisturbed pressure using a tiny surface area.
Correct.
But that immediately makes me wonder about the places where you can't just stick a little nugget of gauze. Like, what happens when a needle hits a major vessel deep inside someone's head?
Now that brings us to some of the most dramatic case reports in our stack.
I was reading these. They are terrifying.
They really are. They focus on the posterior superior alveolar nerve block, or the PSA block.
Right, and for anyone who hasn't had the pleasure, this is the deep injection dentists use to numb your upper back molars.
Yeah, the needle goes way, way up behind the cheekbone.
Just a huge needle going right into your skull.
And it navigates an incredibly dense, treacherous neighborhood of blood vessels. It's known as the pterygoid venous plexus.
That sounds like a sci-fi villain.
It kind of is in this context.
Yeah.
It sits right alongside the alveolar arteries. It's this highly vascular area deep inside the infratemporal fossa, which is basically a loose anatomical pocket that has a massive capacity to hold fluid.
Okay, so it's just an empty space waiting to be filled.
Exactly. So if a needle slightly nicks an artery way up there, the arterial pressure forcefully pumps blood into that empty pocket at just an alarming rate.
The clinical descriptions in these reports are wild. Like, the patient doesn't develop a normal bruise at first.
No, not at all.
They develop this sudden, heavy, completely colorless swelling on the side of their face. It's just this rapid ballooning from the inside out, happening in minutes.
It's very jarring to see, and you obviously can't put a pyramid dressing on a blood vessel located behind a cheekbone.
Right, like external pressure on the cheek does literally nothing because the skull bone shields the bleeding vessel.
Exactly. So the protocol for this requires an immediate pivot. At the very first sign of that deep swelling, the practitioner has to abort the injection immediately.
Wait, okay, but if you abort the injection and pull the needle out, you still have a hole in an artery deep inside the skull.
Yeah.
Aren't you just letting them bleed out internally?
Well, that is why the next step has to happen within seconds. The clinician must immediately apply digital pressure, meaning using their fingers directly to the soft tissues inside the mouth.
Inside the mouth? Where?
High up in the mucobuccal fold.
How do you even reach that? The fold between the cheek and the upper gums goes pretty far back.
Oh, the guidelines state they must press as far distally, meaning as far back toward the throat as the patient can physically tolerate without gagging.
Oh my God.
Yeah, and the direction of the force is absolutely critical here. You cannot just push flat against the inside of the cheek.
Right, because again, you're not hitting the vessel.
Exactly. The force must be directed medially and superiorly.
Medial and superior, so they're pushing inward toward the center of the head and upward.
Yes. They are essentially using the patient's own skull base and the surrounding bony architecture as an internal anvil.
An anvil?
Yes. By pushing up and in, they are trapping that nicked artery against the bone to manually pinch it closed.
Okay, using the skull as an anvil is intense.
It's very intense.
But the dental sources emphasize that this physical compression isn't going to be enough on its own, right? So
Yeah.
they mandate immediate thermal compression too.
Yes, thermal compression becomes your primary secondary weapon here. The protocol requires an extraoral ice pack. So, ice on the outside of the face applied for 30 minutes every single hour for the first 24 hours.
30 minutes on, 30 minutes off for an entire day and night. That is so aggressive. Why?
To induce massive, sustained vasoconstriction.
Shrinking the blood vessels.
Right. The cold temperature physically forces those deep blood vessels to shrink in diameter. It turns a fire hose into a garden hose.
Wow, okay.
So it drastically reduces the volume of blood pumping into that facial pocket while the fibrin matrix is trying to cure. But the timeline is totally unforgiving. Cold is strictly limited to the first 24 to 48 hours.
Okay, but what if a patient wakes up the next morning and, their jaw is super sore from all the swelling, and they decide a hot towel would feel really soothing?
It would be disastrous.
Really?
Absolutely. Applying heat early on triggers vasodilation. The vessels relax and expand, blood flow surges, and you will actively restart or expand the deep hematoma. You are essentially feeding the bleed.
Oh, wow.
Yeah. Warm, moist compresses are strictly reserved for after the 48-hour mark.
Right, because by hour 48, the fibrin rebar is fully cured, the internal pipe is securely patched, and now the heat serves a totally different purpose.
Exactly. Now it increases circulation to bring in the macrophages.
The body's cellular cleanup crew.
Right. They start breaking down and absorbing the blood that pooled in the face, and it helps relieve the muscle stiffness.
It is such a highly choreographed sequence. Like mechanical pressure against the skull base, 24 hours of cold to clamp the vessel, and then heat after 48 hours to initiate the cleanup.
It really is an exact science.
Okay, so deep blocks require intense pressure and ice. But let's look at the complete opposite end of the spectrum here.
Okay.
What happens when the injection is superficial but cosmetic? I'm thinking about hyaluronic acid lip fillers.
Yeah.
Because if applying heavy pressure stops a bleeding vessel, why do all the plastic surgery sources scream at patients not to touch or pinch their lips after getting injections?
It seems like a huge contradiction, doesn't it?
It totally does.
But it all comes down to the chemical nature of the material being injected. Hyaluronic acid, or HA, is profoundly hydrophilic.
Hydrophilic, meaning it loves water.
Exactly. It acts like a microscopic sponge, actively pulling surrounding water into itself.
Okay, so the volume you see in the lip isn't just the gel itself. It's the water the gel is stealing from the surrounding tissue.
Precisely. And when you combine that intense osmotic water pulling effect with the natural histamine release caused by a needle repeatedly piercing the lip,
Which makes the capillaries leakier, right?
Yeah. Right, you get an inevitable dramatic swelling peak at the 24 to 48-hour mark. It's often called the duck lip phase in the industry.
The phase where the patient looks in the mirror and thinks they've ruined their face forever.
Yes, exactly. The panic phase.
But back to the hemostasis thing. If my lip is oozing from the needle, why can't I just pinch it for 3 minutes like the nugget method?
Because the practitioner just executed a bespoke, millimeter-precise placement of that HA gel to sculpt the lip.
Oh, I see.
Yeah, if you apply mechanical pressure, like if you massage or pinch those tissues, you will physically migrate the gel before it has integrated into the cellular matrix.
Oh, yeah.
So you might stop a minor bruise, sure, but you will permanently warp the cosmetic result.
You save yourself a bruise, but give yourself a completely lopsided mouth.
Pretty much.
So how do you manage the hemostasis if you can't even touch it?
The lip protocol abandons mechanical pressure entirely. Instead, it relies exclusively on thermal and postural compression.
Postural compression.
Let me explain the thermal first. The strict instruction is to apply a cold compress wrapped in a clean cloth barrier so ice never directly touches the delicate lip mucosa.
Because that would just cause more damage.
Right. And you do it for 10 minutes on and 10 minutes off.
Just enough cold to constrict the surface capillaries without freezing the tissue or risking frostbite?
Exactly. And then for the postural compression, that simply means using gravity.
Oh, okay.
The patient must keep their head elevated on 2 pillows overnight. You are using gravity to physically drain lymphatic fluid down and away from the face, preventing it from pooling in those hydrophilic HA pockets while the patient sleeps.
Keep your hands off, cool it down, and let gravity do the heavy lifting.
That's the secret.
Okay, that brings me right back to the GLP-1 weight loss injections we talked about at the very beginning of the deep dive.
Yes, the at-home injections.
Right. People are doing these subcutaneous shots in their stomach or thigh at home. And the number one complaint I hear is about these dark, lingering bruises.
Well, the GLP-1 protocols actually provide a very distinct mechanical blueprint to prevent this. First, they dictate a 45 to 90-degree needle insertion angle.
Okay, why that specific angle?
This minimizes lateral shearing of the tissue layers, but the crucial step happens after you push the plunger.
Okay.
You must hold the needle in place for a full 30 seconds before withdrawing it.
Wait, hold the needle inside the skin for 30 seconds. Isn't that just keeping the puncture wound open longer than necessary?
It seems so counterintuitive, I know, but it's essential for the fluid dynamics. You need to allow the medication time to fully disperse into the subcutaneous fat.
Oh, I see.
If you pull the needle out immediately, the localized pressure of the fluid you just injected will force the medication to track right back up the needle path and out of the skin, bringing blood with it.
Wow, okay.
Waiting equalizes the pressure. Then, when you finally withdraw the needle, you hold gentle pressure for exactly 10 to 15 seconds.
And this is where we get to the rubbing. Because instinctually, we rub a shot to make it stop stinging. Right.
Yes. And what's fascinating here is how explicit the medical sources are on this single point. Absolutely. Under no circumstances should you rub the site.
Because I'm visualizing the wet concrete again.
Uh-huh.
If I rub the skin, I'm taking that microscopic 30-second platelet plug, and I'm violently smearing it around
Yeah.
before the fibrin rebar has a chance to set.
You got it. You are physically tearing the wet concrete out of the pipe. The friction shears the fragile capillaries all over again.
Yikes.
By rubbing it, you take what would have been a microscopic, basically invisible capillary ooze, and you actively spread the blood under the skin, creating a highly visible, spreading hematoma.
I am having a major realization here. Like, I have been giving myself bruises my entire life just by rubbing my arm after a flu shot, thinking I was helping.
You and millions of other people.
It's amazing how much damage a seemingly harmless rub can do. But, okay, let's push this to the absolute limit. We've covered external physical pressure, we've covered deep anatomical pressure against the skull, we've covered postural gravity. What happens when the oozing is on a mucosal surface where you cannot possibly apply physical pressure, and you obviously can't use gravity?
You mean environments where gauze just gets soaked and falls off, or internal areas you simply cannot reach?
Exactly. Like deep inside the gastrointestinal tract, or even a superficial, constantly wet wound inside the mouth. It's like trying to patch a leak deep inside a sealed engine block. You can't get a wrench in there, and you can't hold a thumb on it.
Well, if we run with that engine block analogy, if you can't reach the leak, you have to pour a chemical sealant into the system, one that is specifically engineered to only harden when it makes contact with the leaking fluid.
Oh, wow.
In the body, we have to achieve hemostasis chemically.
And the biomaterial protocols in our stack detail some truly wild workarounds for this. Let's start with the mouth.
Okay.
For minor oral mucosal oozing, where pressure won't hold, the sources suggest applying a hypertonic 10 to 20% sodium chloride solution with a gauze pad.
Yes, essentially a highly concentrated saline solution.
Which is literally salt water. How does salt water patch a blood vessel better than pressure?
It is entirely about osmolarity.
Okay, unpack that for me.
That hypertonic solution has a massive concentration of salt. When you place it against the wet mucosal tissue, the salt acts like a magnet.
Okay.
It literally draws intracellular fluid out of the surrounding tissue and into the blood vessels. But as it aggressively pulls that fluid out, it drags a very specific protein called tissue thromboplastin along with it.
Okay, I saw thromboplastin mentioned in the sources, but what is it actually doing in plain English?
It acts as an external fire alarm for the body's clotting system. We call it the extrinsic clotting pathway.
Extrinsic meaning coming from the outside.
Exactly. Normally, blood clots when internal triggers within the bloodstream sound the alarm. By using salt to forcefully drag thromboplastin out of the surrounding tissue cells, you are bypassing the blood's internal sensors.
Oh, that is wild.
You are chemically forcing the local tissue to orchestrate an immediate, massive clotting cascade exactly where the fluid is escaping.
You are literally weaponizing the tissue's own fluid dynamics against the bleed.
It's incredible, isn't it?
That is brilliant. But obviously, you can't just pour highly concentrated salt water down into someone's stomach to fix, like, a bleeding upper GI ulcer.
No, you can't. For deep internal mucosal bleeds, the gastrointestinal trauma sources outline the deployment of advanced biomaterial powders, things like hemospray or endoclot.
Right.
These are absorbable hemostatic polysaccharides delivered directly through an endoscope.
So just to picture this, a gastroenterologist is navigating a camera down into the stomach, finding a bleeding ulcer and just blasting powder at it.
It sounds kind of crude when you say it like that, but the cellular reaction is phenomenal.
I bet.
These specific powders are designed to react instantly when they make contact with blood. They rapidly absorb the water content out of the blood itself.
Wait, they're dehydrating the blood as it exits the vessel?
Exactly. By pulling the water out, the powder instantly super concentrates the red blood cells, the platelets, and the clotting factors that are left behind.
Oh, if you take the water out of wet concrete, you're left with a solid block.
And that is precisely what happens. This rapid dehydration creates an instant, gel-like mechanical tamponade.
Wow.
It forms a highly adhesive protective shell that bonds directly and fiercely to the bleeding tissue. It builds its own pressure patch from the inside out, completely eliminating the need for a surgeon's finger to hold it there.
So really, whether it's a routine vaccine, a deep dental block, a lip filler, or an internal ulcer, the body's rules for stopping a bleed are completely non-negotiable.
They absolutely are.
It's either a 2 to 3 minute physical hold for the fibrin rebar to set, specialized spatial awareness to trap a deep vessel, strict temperature control to manage the plumbing, or chemical dehydration to force a seal.
Right. If we connect this to the bigger picture, Hemostasis is never just a one-size-fits-all action. It is a highly localized, incredibly delicate negotiation between the structural type of the tissue, the exact depth of the injured vessel, and that rigid biological clock.
Yeah.
When we respect those parameters, the body heals brilliantly and invisibly. When we try to rush it like rubbing a shot, we get the bruising, the swelling, and the prolonged complications.
It really reorients how you view even the most minor medical procedure, like I'm never rubbing a flu shot again,
Good.
which sadly brings us to the end of today's deep dive. But before you go, I want to leave you with one final thought to mull over.
Oh, I like these.
Yeah. So we have spent this entire time exploring how to instantly trigger the body to build a clot to stop the bleeding, right?
Yeah.
We are obsessed with getting that clot formed as fast as possible.
Right, because bleeding is bad.
Exactly. But what if, in the near future, nanotechnology could allow us to program the exact timestamp for when that clot safely dissolves?
Oh, now that raises a fascinating implication.
Right. Because imagine a world where a hemostatic powder not only stops an internal bleed instantly, but is chemically programmed to dissolve harmlessly and precisely 72 hours later.
That would be revolutionary.
It would entirely eliminate the dangerous risks of post-operative thrombose or strokes caused by runaway clots. We wouldn't just be starting the biological clock, we'd be setting the alarm for exactly when it ends.
Incredible to think about.
Truly. Well, thank you so much for joining us on this deep dive. Until next time, keep questioning and keep exploring.